I want to thank you all for coming this evening. This is our quarterly chapter event for the Open School, the IHI Open School here at Frontier Nursing University. I'm Dr. Christopher Kennedy, and I'm one of the DNP clinical faculty for those who don't know me. And we have a real treat tonight. This is actually going to be a precursor event to another event that we're going to be holding with the Right Care Alliance on Tuesday, November 10th at 8 p.m., where we're going to have study groups where we all get together, and based on topic area of interest, we're going to discuss different areas of right care in healthcare. And I think it'll be a really fun experience. We're going to have some facilitators from the Right Care Alliance here to help us with these so that even Frontier faculty can participate. We're usually facilitating, but it'll be nice to join the discussion for once, right there next to the students and anyone else who wants to join. So that'll be open to anybody who wants to come. Bring your friends from work, other healthcare friends, past graduates, anybody that wants to join. So that will be Tuesday, November 10th at 8 p.m. You'll hear more about the Right Care Alliance tonight. So before we start, we do have a special guest this evening. We have Dr. Vikas Saini. He's president of the Lown Institute. He is a clinical cardiologist trained by Dr. Bernard Lown at Harvard. He's done research. Do me a favor, if you join, please mute your audio so that we don't get a lot of extra noise. Thanks. So Dr. Saini is a clinical cardiologist trained by Dr. Bernard Lown at Harvard, where he's taught and done research. He has also been an entrepreneur as scientific co-founder of Aspect Medical Systems, the pioneer in non-invasive consciousness monitoring in the operating room with the BIS device. He was in private practice in cardiology for over 15 years on Cape Cod, not a bad location, where he also founded a primary care physician network participating in global payment contracts. Dr. Saini is board certified in cardiovascular disease, internal medicine, and nuclear cardiology, and he served on the faculty of Harvard Medical School and the Harvard School of Public Health, where he initiated the first course focused on policy translation for cardiovascular disease prevention. In April 2012, Dr. Saini convened the Avoiding Avoidable Care Conference, the noted author Shannon Brownlee. This was the first major academic conference focused on the problem of overuse of healthcare services. Dr. Saini led the international writing group of the Right Care series of papers commissioned by The Lancet and published in January 2017. With Ms. Brownlee, he's a convener of the Right Care Alliance, a grassroots network of physicians, nurses, patient activists, and community leaders dedicated to creating public demand for care that is safe, effective, affordable, and just. Dr. Saini has spoken and presented research about avoiding unnecessary care at professional meetings around the world, and has been quoted in numerous print media, radio, and television. So as many of you can see that are joining here, all of the things that Dr. Saini is passionate about are things that you are seeing all throughout your curriculum, whether you are working on your master's, your DNP, or whether you're coming from outside to join us tonight. So without further ado, I'm going to turn it over to Dr. Saini.
Thank you. Thank you very much. I reminded that the older you get, the longer your intro gets. That doesn't necessarily make it more consequential. So thank you for that introduction. Yeah, I've done quite a bit and have, I think, very broad perspective on the healthcare system. I want to first spend a few minutes and tell you a little bit about the Right Care Alliance. And then I'll spend most of my time talking about a new hospital evaluation index that we developed and released this past July at the Lown Institute. And some of this stuff will be, technical, but not really. And some of it will be just very clear and plain and, maybe even obvious, but important, I think. So let's start with the Right Care Alliance. This slide that's been there since we started, I think, captures a lot of what's wrong. I was just reading the other day polling data, and of course, people are polling about the election all the time, but not just in terms of who's ahead or the horse race, but what issues really matter to people. And I will say that in my lifetime, it was always, almost always, the economy. And only in the last few years has healthcare been a top 3 issue, and excuse me, as recently as last year, the top issue, and that was before COVID. So I think part of what we're all looking at and what we all need to grapple with is whatever the outcome of the elections, the reality that we face in healthcare in America needs serious attention. I'm not going to belabor these points. You can't really open a newspaper, magazine, or even journal these days without a lot of discussion and opinion about what's wrong with our system. But the Right Care Alliance has an approach, a slightly different approach to this. And it arises from this fundamental belief that there's a problem in how we're connecting to each other and also how we're talking to one another about problems. So for us, a core idea is really that when we face serious tragedies, and I would say the pandemic is in that category. This is a picture from a hurricane. I think this is Houston, where people were flooded out, and nobody really asked questions about your insurance status or your political persuasion or anything like that. In moments like this, we come together and we tackle problems and solve them, and that's really, I think, one of the core motivators of the Right Care Alliance. We're not particularly focused on elections and electoral politics. We are focused on what's wrong with the system and how to make it right. One of our core views is that the way to do that is really for an alliance of clinicians, patients, family members, leaders in the community, and activists. We are unabashedly activist in the sense that we think it's important to take action visibly, and to really call things that need to be called out, but also offer paths to solutions. And we think if we do that, a lot of the dysfunction in the system can come together. This is a visionary perspective, but in some ways, unless you have that vision, it's really hard to navigate. So our view is we kind of know what it really should look like. The core question is, how do we get there? And so for us, how we get there is that really there's a cyclical pattern of engagement, building leadership, working around a specific task and with priorities, using the power of people and grassroots organizing, and developing that in a way that builds a sense of cohesion and power to tackle specific issues and grow and build the network. So that's kind of our theory of change, if you will. And with that, we have really embarked on some campaigns. This is a picture of the price of insulin. And what you see here is, for a couple of these, and many of you may have heard about this and read about this in the media, but when we in the Right Care Alliance first started looking at this question, it was about 4 years ago. And what we saw astonished us. And the more we heard about it, the more we realized we had to take some form of action. These are Mother's Day cards that this is kind of an in-your-face campaign, but these are Mother's Day cards, and these are the moms who lost their children to rationing insulin because the children couldn't afford it. Children often, almost always, were too embarrassed to tell their parents or family about what was going on. And these are people who died because they couldn't afford their insulin. So this was a campaign we gathered signatures, we delivered these Mother's Day cards, we spoke to the media, and then we went even one better. We began organizing, began pulling together people in various communities. And in Boston, this was at Harvard Medical School. It was a cold day. There weren't a lot of us, but we decided to make our presence felt. People gathered, came to see what we were talking about. And in that way, in that kind of style, we began to raise awareness. we actually held protests here in Boston at one of the insulin manufacturers, Sanofi, because, you know, the price of insulin in the 20 years that these, I'm going to say kids, but these people young people who died, in the 20 years that they were using insulin, you know, the price of insulin had gone up by 10 times with no change in patents, no change in formulations, nothing. It really was unjustified and really unjust. And our core view in the Right Care Alliance is that these kinds of issues have to pull us together, have to tackle these. And sometimes it's uncomfortable. Sometimes we take on issues that are controversial. But in the process, we think we're building the basis for a grand alliance and for some changes in American healthcare. So that's our vision. It's open to any and all. Clinicians are welcome. Patients are welcome. It's one of the few, maybe the only organization I know of in which you can actually be on an equal footing. It's pretty democratically run and it's volunteer driven. And on that basis, what we do is make decisions democratically. So if any of that sounds like it's appealing to you, then you can check us out at therightcarealliance.org. So I wanted to start with that so you have some understanding of who we are. I think the study group that you're going to be having is, I think, an opportunity to hear some of the other elements of our thinking, which is a broad transformation of the healthcare system in many dimensions and directions. So I hope many of you will join that. So I'm going to pause and turn to the Lown Hospitals Index.
So, well, thank you. In transition, Dr. Kennedy is going to upload those next files. This is Dr. Jolles, and I just want to see a show of hands. Just type in the chat box if you are a DNP student who has used right care as one of your concepts in your paper. Let us know who you are, where you are, what your topic was. We're really proud of all of our right care projects. Great to see so many people here from all over the country tonight.
You see in the next, are you seeing the hospitals index slide deck?
Yes,
oh,
I am.
that was a seamless. I thought this was the last.
Yeah,
we'll type it in. And let's roll.
Great.
Yeah, no,
well,
make sure you can see it.
Yeah, no, I can see it. Thank you, Dr. Jolles, for that. It's a pleasure to be here. So let me tell you a little bit about the Lown Hospitals Index. We rolled this out in July. The Lown Institute, which is sort of the organization under which the Right Care Alliance works, is a think tank. We believe in a very different healthcare system. This is Dr. Bernard Lown, my mentor, leaning against one of the very first commercially available defibrillators in the United States. He led the team that developed it, rocketed to international fame, and for 30, 40 years was a prominent cardiologist, world-renowned, and an activist who actually won the Nobel Peace Prize in 1986 for his work on nuclear weapons treaties, which was actually just in the news today, I think. The Lown Institute, we think of ourselves as sitting in the middle of these three big pillars. High value. We don't think unnecessary care or waste is doing anybody any good, and we need to figure out how to eliminate it. Health equity in terms of all of the people in the country having access to health care and having access to good quality health care, affordable health care. Accountability. We think that what's critically missing really in many institutions in healthcare is a real responsiveness to the very people that we are meaning to serve and trying to serve. But too often this gets missed or lost in the routine and in the bureaucracy and all the different complexities of healthcare. And the Lown Hospitals Index we think of as right down the strike zone of all three of these. And hopefully when you see what we've done, you'll agree. But the first thing we recognized is that you really have to keep clear in your mind the difference or the distinction between health and healthcare. And many of you may know, but many may not, that a lot of studies have tried to calculate and quantify the contribution of different things to life expectancy, to longevity. And most credible estimates only give healthcare only about 10 to 15, maybe 20% at the most as a contributor to longevity and life expectancy. All the rest has to do with many other things that many of you will be aware of, including, your education, your resources, chronic conditions, habits, lifestyle, all those dimensions. So it's important to remember that, because when we talk about assessing hospitals and assessing clinical care, it's important to remember that that's only a small part of the story. But because healthcare is so prominent and takes up so much money and has so much authority and prestige, it's very clear that hospitals matter to all of us. And in fact, I would say most people, when they think about health and healthcare, would almost by default start thinking about their local hospital. And hospitals are central to communities increasingly all over the United States. So the question is, what's good, and how do you measure what's good? That's what we tackled, and that's kind of how we decided to make another hospital ranking. And really, I guess the answer to the question, why another ranking, is that when you look at the rankings out there, many of them make some sense technically, especially when you talk about mortality, for example, or the reputation of different specialties in different hospitals. But given how important hospitals are to communities, we also decided to ask the question, what matters from a community level? What should matter? And so we began to imagine other metrics, things that aren't used in US News, for example, that metrics that aren't used in IBM's measurements, or really Medicare or anybody. And so we began to imagine this in a way that might be much more relevant to our current situation. This is a picture of lines outside a hospital in New York City in the midst of COVID. These are people waiting to get tested. And this line went way out. And as you may know, in parts of New York, they were slammed. There were disproportionate impacts in communities of color and poorer communities. COVID really hit them hard. And the hospitals that took care of those people were performing an important and essential service, I would argue a national service, really. And yet most of those hospitals do not get named in the big magazine rankings. So we wanted to try to address that. So we looked at a range of measurements. We looked at the one everybody tends to look at, mortality. We looked at readmissions, though there's a lot of controversy about whether that's even a very good measure of quality. Probably some readmission is a measure of quality, but a lot of it is not in anybody's hands, really. Much of this is the play of chance and many variables. Patient safety, patient satisfaction, all reasonable. And then we added a bunch of things that are new and have never been used in hospital rankings before. We created a measurement called avoiding overuse, things that don't really work, and why are we doing them? We created a measure called inclusivity, which was based on hospitals' treatment of their patients and the demographics of the patients inside their four walls compared to the demographics of everybody around the hospital. And I'll show you how we did that. We looked at their community benefits investments, and we looked at pay equity, which is how much does the top person make in relationship and as a ratio to what the average non-professional worker makes. And we can talk about why we did that, but those are the ones we did, and that made this whole thing quite unique. Pretty complex. It was a 1.5-year project. We're now working on number 2. A lot of data from a lot of different sources. But broadly, these 3 areas: civic leadership, value of care, patient outcomes. And so we'll talk a little bit more about each of those. We also had the benefit of an advisory committee that included clinicians, business people, public health specialists, couple of hospital CEOs, somebody from the media, former editor of Modern Healthcare, a couple of technical people. So it was a good group, and they helped us a lot. Certainly helped us avoid rookie errors, because this was sort of our first outing with this. We created a hospital website, the lownhospitalsindex.org. And really, if you want to explore this further, that's where you got to go. And I'll show you some of the capabilities, but you really have to see it to understand it. This is a quick snapshot. It shows you that, you can pick the type of hospital you want to look at, whether it's a teaching hospital, a safety net hospital, urban, rural. You can check hospital size. Then you can look at specific measures that we have created. And then it'll give you a ranking. So in this case, it's charity care and community benefit spending. And this is Boston or Massachusetts. And, just to give you a flavor, the big name hospitals, the Harvard hospitals, Mass General, or the Beth Israel, Brigham and Women's, I mean, they're there. But the number one was Boston Medical Center, which is associated with BU. And UMass Medical Center was right in there. And so part of what we expected to happen started happening when we got results, which is there were a lot of unsung heroes, a lot of institutions that are doing important, good work that really ought to be recognized. And so we're pleased that that's kind of what we started seeing. This summer we launched, we got a lot of press. I mean, we were pleased because everything was about COVID all the time. We didn't really talk about COVID, but we got a fair bit of coverage. And our sense is that, several million people at least heard about this and heard about the concept. And for us, that was probably the most important goal, was to reframe how people think about these things and begin to promote a different way of looking. So these are just some of the places that we were covered. And that headline from USA Today is kind of typical of what it was, which is these rankings grade their commitment to community. Again, I'm just showing you some Boston hospitals, mostly to show Health Alliance of Clinton, which I didn't even know about. Living in Massachusetts, working in healthcare, I kind of knew about the town of Clinton. I knew that there were hospitals in the UMass system. I didn't know about this hospital. So let me talk a little bit about civic leadership. So that's one of the three legs of the stool, if you will. It has these three: community benefits, pay equity, and inclusivity. So for community benefits, you use information from nonprofit 990 forms that the IRS requires. We also used information that Medicare collects. And in between those, we were able to grade not just nonprofits, but government hospitals like county and city hospitals, and for-profit hospitals, especially the publicly traded ones. We looked at pay equity. And in this case, it was a lot of work because, again, the for-profit hospitals, we had to go to the SEC. You'd think public and county and government hospitals would be easy to get information, especially about CEO pay, because it's, public money. But actually was a challenge, and it took a lot of legwork. And inclusivity, which is one of the ones that most of the media took great interest in. It was around the time of this upsurge of concern about racial inequalities in the country. And so what we had done was we had looked at inclusivity by education, income, and race. And so that gave a very different perspective on how one might look at hospitals. So this is just a map of the states, and this shows civic leadership state by state. Again, this is a combination of pay equity. I'm blanking for a second, excuse me. The inclusivity and community benefits. And I don't know that there's really a pattern to speak of. I mean, I don't know what, so the highest ranking states, New York, West Virginia, Kentucky, Tennessee, New Mexico, Wyoming. I mean, I don't quite know what to make of it, except to say that it's interesting. And in some ways, this is food for a lot of follow-on research. On the website, you can actually see how we graded them. We did a combination of stars and then actual percentiles. It's kind of not that interesting unless you're doing some particular piece of work, but it illustrates how we show this. And this just, for us, what was important to start a conversation. How much, I don't know what's the right amount for a CEO to make. CEO of a hospital, it's a complex organization. It's really challenging. But it is true that the nonprofit hospitals are doing very well, and certainly people in the C-suites are doing very well. The American Red Cross has $2.8 billion in revenue, and the CEO makes about $680,000. Mount Sinai Medical Center in Florida and Miami has less revenue than the Red Cross, about 2.4 billion. CEO makes 2.2. Is that fair? I honestly don't know the answer, but I do know that this is the kind of question we need to have more open public discussions of, both in academia, in research circles, and certainly in policy. And I will say, editorializing that in a period when many, many, many hospitals are struggling and the federal government is bailing out many, many hospitals in the billions and billions of dollars, I think it's a reasonable thing for the public to ask. Community benefit spending, we used a combination of charity care, community improvement efforts, community building efforts. And we also added, as sort of balancers, Medicaid as a percent of total revenue. We gave that a smaller weight, but we felt it was important to give it some weight because there are really a lot of aspects to what is serving a community that is reflected in that. And it was the only way we could compare states that expanded Medicaid and states that did not. So now, this is that hospital that I hadn't heard about, Health Alliance in Clinton. So it turns out that when we talked to them, we discovered that they have a plan to spend 1% of their endowment on affordable housing in their community. Didn't know about it. They knew about it. We were happy to bring that to the surface and let others know about it. It's the kind of activity proactively that if a hospital is doing, we think they should get recognition. So we were delighted that this was one of the things that we found. So let me talk about inclusivity because it got a lot of interest from the media. As I said, we looked at income, race, and education. This, by the way, is the actual ranking for that hospital, Health Alliance in Clinton. And what you see is they're incredibly inclusive across all three of those categories, and they rank very, very highly in the nation for that. What we're seeing around the country is that this measurement that we've developed, inclusivity, is a tale of two hospitals. Those of you who've read Dickens' A Tale of Two Cities will recognize it. Those of you who haven't, go read it. But what we found, the way we did the calculation was we took all the patients who come to a hospital. These are Medicare patients, by the way. So this is actually not about which patient can pay more, because Medicare pays the same. But nevertheless, there are differences, cultural, all sorts of differences that are driving this. And what we did was we looked at the patients who come to the hospital. We analyzed their geographic footprint. And then we drew a circle around that geographic footprint and then looked at everybody inside that footprint, even the ones that don't come to the hospital. And then we compared the income, race, and education of those that come to the hospital with the average of that entire footprint. And that difference was a measure of how inclusive the hospital was. So on the left, you have Mass General. On the right, you have Boston Medical Center. They are, well, my guess is 2 miles apart, if that. And the catchment areas, as we define them, this is the proportion of people of color, minorities, in the Mass General's catchment area, 17%. Here it is for Boston Medical, 19%. That's their catchment area. And then this is the actual patient population of each of those hospitals. So the Mass General's catchment area is 17. Patients in the hospital, about 14% are people of color, minorities. Boston Medical, it's in the other direction. 19% in the catchment area, 45% of their patients, nearly half their patients, are from minority populations. And it illustrates a kind of almost social function that these two hospitals are playing. It's not news to anybody who knows Boston, and practically in every city in America, if you look at it, you'll see this pattern. It's not news, but by developing a measure, we thought we should bring it under focus and begin to ask questions about how it is and why that is. So it turns out tomorrow, just by happenstance, we're going to be holding an online session with Mary Bassett, who's at Harvard now, but was the former health commissioner of New York City, and Milton Nunez, who's the CEO of Lincoln Medical Center in the Bronx. And Lincoln placed #1 in the nation on inclusivity on our rankings. And so we're going to be having a session tomorrow talking about all that. So if you have the time, please join us. You can register at lowninstitute.org /racism. This is 2 other hospitals also in the Boston area. One is Mount Auburn on the left, the other is Cambridge Health Alliance. And these are both in Cambridge, and they're about 2 miles apart. And the mean income of the catchment area is almost identical between the 2 hospitals. And here you see again this sort of separation of by income of patient population. So clearly Cambridge Health Alliance is serving a different population than Mount Auburn. They're not far apart. So it's really something about how the system is organized, comfort levels, habits, referral patterns, and of course, insurance and money. It has to be playing a role. Though, as I pointed out, the data is for Medicare, where money is not an immediate driver. This is something that may, over the lifetime of a patient, have led to where they get their care. And by the time they're on Medicare, they're not going to switch. So I don't pretend to have all the answers, but these are the observations that we used for inclusivity. Let me talk briefly about value of care. We looked at 13 unnecessary procedures. And when I say unnecessary, that means almost all the time. There are always instances, any clinician will tell you, there are always instances where it might be a reasonable thing to do. But based on what we know, so for example, knee arthroscopy, there are 2 randomized trials using sham surgery in which a true control group had a fake surgery. So it was the placebo effect was active. And 2 of those failed to show a significant clinical benefit. So that's how you would get into this list. So we counted these in Medicare around the country, and then we added them up and then ranked hospitals. And here's an example for hysterectomy, for example, which has sort of been in the news lately for other reasons. And what you see is that in our definition of unnecessary hysterectomies are hysterectomies that are essentially done for non-malignant conditions. So benign non-malignant conditions. And what we see is that there are a lot of hysterectomies that are done for benign conditions. And quite a few met our criteria for overuse. What's interesting is the pattern, again. I think there's sort of a pattern of being rural. That's, if I were to say what the pattern is, I'd say that's what it is. There may be some kind of racial component. We haven't looked at that yet. But this illustrates something that our data shows, and again, rich data sets that probably have a lot more to tell us. So that was hysterectomy. This is overuse as a whole, and lighter colors are better and darker colors are worse. And what we see in this case is Florida in particular, parts of Arizona and Nevada, and Maryland, which is actually quite interesting. We have a colleague at Johns Hopkins who's done an index of overuse, and they also had Maryland fairly high. I'm not sure what's going on there, but there you are. That's at the state level, and of course, there are many hospitals in each state, so maybe there's something to say about it or not. And then finally, patient outcomes, something that is very important. We weighted our overall rankings 50% with patient outcomes, and in particular clinical outcomes. And for clinical outcomes, we looked at in-hospital mortality, 30-day, 90-day. We looked at readmission. So these are kind of the more traditional measures that are used to rank hospitals. And we used a very accurate risk adjustment tool that's been in the public domain but hasn't been used much. And we applied it. And for the data geeks in the audience, this is a performance marker of how well this risk adjustment tool does. A perfect risk adjustment tool would literally be a right angle. It would go straight up and go straight across. This is the sensitivity for detecting, in this case, 30-day mortality. And this is 1 minus specificity. And so what you get is what's called a receiver operating curve. And the area under that curve is a measure of the accuracy. So the more bow you get, the more area is added, the more accurate you are. So our technique is more accurate than the one CMS currently uses, which is in the green. And again, it's important for predictions and other things, but the fact that you can calibrate it into a straight line is really helpful and important. So, never mind the technical part, but just to say, we applied a tool that we think is at least as good as any other, probably best in class at the moment. And what you see here is that now you see some familiar names, brand names of varying sorts. 30-day mortality, Houston Methodist, Northwestern in Chicago, University of Colorado. There's Johns Hopkins. And for 90-day mortality, there's Mayo Clinic. So you'll see some of the names that you're familiar with. But even in mortality, we used a method in which we took all patients coming to the hospital, most of the ones from US News and IBM, stitched together 3 or 4 conditions like heart attack, stroke, pneumonia, about 3 or 4, sometimes 5. Stitch them together and create a measure. We actually literally took all patients coming, applied that risk adjustment tool, and got these results. So we're proud of this. We're able to defend it, but the names are not always exactly the same, and that was our goal, to try to cast a new light on how we look at hospital care. So this is a map of patient outcomes by state, and in this instance, my state of Massachusetts does quite well. And I think that there's probably correlation with non-medical stuff going on. So for instance, in Louisiana, Mississippi, in that part of the world, we know there are a lot of health disparities, racial disparities, poverty. Those are probably driving a lot of these outcomes. Measuring hospital care is giving you a window on that. It's not always necessarily the case that the hospital can do much about that. So that's always a caveat we have to talk about when we talk about why we rank hospitals at all, which is the first point I made at the very start about the difference between health and healthcare. So this is from our website, and it really shows some writing that we've done. You can go to the site and you can get some white papers if you want to understand what we did, or just have some insight into what's going on. And that's all I have. So I'm going to stop there. I know it was sort of a whirlwind. I'm happy to circle back to any one of these things. And I'm not going to be able to scan the comments for questions. So if my host can help me out, we'll take some questions if they're there.
Sure. Thank you very much. That's a great presentation, great information. We really appreciate that. If anyone has any questions, we've been watching the chat box. So on the side, there's been kind of a lot of back and forth going on, especially the information about hysterectomy seem to have struck a note. We have quite a few midwives, women's health nurse practitioners in our ranks here. So they're very familiar with the issues surrounding that. I haven't seen any questions just yet. And feel free also.
I have a question.
Right.
You definitely have lit the chat box on fire. And I do want to just let you know that we've had 200 Doctorate of Nursing practice projects that use right care as a metric. So they operationally define right care somehow.
Wow.
And yeah, so you are in your family crowd right here.
Wow, that is awesome.
Yeah, and with that in mind, and just seeing all of the comments, I would like to hear from you a story about your how you weather the resistance, because I can only imagine you have come across extreme hatred or yeah. So, and we are a community of 3,000 advanced practice providers who are focusing on primary prevention, primary care, and midwifery. And so the system is very much set up against those things. So we live this every day, and there's a high rate of burnout.
Yeah. Well, so in terms, I mean, there are many questions packed into that one. So let me just start with what you said first. I don't know. You know, you just have a thick skin. We haven't actually had a lot of overt hostility. I think, I mean, the American Hospital Association said a few things in the media that, you know, kind of were dismissive of us. But it was sort of telling that one of their strongest criticisms was that we hadn't used properly vetted tools vetted by them. And so that's why this was not really that important. So I would say that, you know, we expect that the resistance will be mostly at the technical level, and we're pretty confident that at that level we'll be able to hold our own. I think that, you know, in many ways, we're using public data. We didn't make any of this up. You know, the methods are transparent. Anybody else can use them. So we're just presenting, you know, what are effectively, you know, is the facts in the data that we have. So if someone has an argument with the method, you know, we can talk about that. But in terms of the results, I mean, you know, it's like any other exercise like this. You know, you can have your opinion, but you can't have your own facts. So with regard to the other question, that's a tougher question. It's really about, I mean, what I heard you say and what I know is that, you know, it's a real struggle, right? There's a sort of a certain amount of moral injury. There's a certain amount of, you can imagine what a system could be like, and then what you see how it is, and it just creates this incredible internal angst and anger sometimes, and sometimes despair, depending on how exhausted you are and burned out you are. And all I can say is those are real. I mean, they're real for a reason, because they're real problems. But I also think that that can be a motor for change. And the key for all of us is to harness that, because it's that disjunction between what is and what ought to be that is what drives everyone always to try to do something better. In this instance, it's a huge complex system, the healthcare system. So there's not a silver bullet. I mean, I know a lot of people think that single payer would fix it, and I will say single payer would fix a lot, but not everything. There's no single silver bullet. And in fact, because it's so complex, we need all hands on deck. And probably the most reliable thing about any of this work is to be with somebody else, with others. That was why we conceived of the Right Care Alliance, because that's how we think it's going to move forward. It's not so much that you elect somebody in Congress and they'll pass a bill or a law. It's really that you build a community with an alternative point of view, and you begin to expand that community and begin to effectively proselytize and win over many more people. And over time, that's usually how things work. It's not easy and it's not always fun, but it's deeply, deeply meaningful given what we're seeing with COVID. My Lord, it is so meaningful.
We do actually have some questions coming in. So Rebecca and Johnny both asked, and you kind of touched on this. Does the Right Care Alliance have an explicit position on single payer?
Yes, the Right Care Alliance. I mean, it's we haven't trumpeted it much yet, and that's mostly just because of everybody's bandwidth. But over the past year, we endorsed a document called "A Call for a New Health System," which is now on the Right Care website. It's still circulating amongst members. We haven't done a big full release yet, but it calls for single payer system. But it calls for single payer system under much more democratic control of healthcare, and so it calls for a lot more than just a change in the payment mechanism. And in terms of the Right Care Alliance, the leadership team has felt that it may be necessary, but it's certainly not sufficient. We need more primary care. We need more attention to neighborhood-based care. We need more attention to long-term care. There's a range of things we need to do that current Medicare is just not the model for.
And for those of you that are here, the group or the study groups that we're going to have on the 10th of November, the topics are coming from that call for a new healthcare system. So those will be the areas that the Right Care Alliance has identified as part of that document. Will be the topic areas that you'll have to choose from if you want to come and discuss. So we have Katya, and she asks, have any hospitals made any changes based on the information that you've provided them?
Not yet, but it's still pretty early. I mean, most hospitals were just contacting us in July and August. We've had various dialogues, and they want to make some changes. They've asked, and the funny thing about this is some of what we're measuring is actually not in the control of a hospital administrator because it's more around policy. So in that sense, it's kind of unfair, but we wanted that conversation. So we do think hospital leaderships need to kind of join a movement for transformation of healthcare. So if anything, even if they can't make changes right within their own institution, if they recognize the need, they can band together with others. They have a lot of clout if they begin to change their views.
All right, Laura works at a federally qualified health center, and she had a question about the insulin prices. She said they're currently looking for cost benefit for the patients. They just had a list of drug manufacturers who pulled out of the 340B program, and many brands of insulin are on that list that have pulled back. Is this a consequence of the movement to provide affordable medications? And how does this benefit the most vulnerable?
Well, I don't think it's a consequence of the movement. I think that a lot of what's going on in terms of drug pricing and the policies on pricing of the pharma industry is really a matter of gamesmanship. And of course, with COVID, things are still very much in flux, and we don't know where things are going to land. But before COVID hit, what was clear was the amount of public scrutiny around drug prices had reached a boiling point. President Trump was talking about it and was trying to, and I think even recently has been trying to get, one of these discount cards in seniors' hands. But that white hot interest led to a lot of efforts at reform, none of which have really had a serious impact on pricing. So if companies have withdrawn from 340B plans, it's for reasons of their own that I'm not aware of or privy to. If others know it, I'd love to hear about it. I think there's a lot of maneuvering and jockeying, and there's a lot of political infighting. And that's all I know about it right now.
All right, thank you. Virginia asks, did you consider including pediatric and military hospitals in this? I was wondering that as well, because I know Boston Children's Hospital is a biggie.
So here's the thing. Our mortality data requires big data. So this is the algorithms we use really to be precise enough to include all hospitals that we did include. Really need large data sets. So we're using Medicare's data set. We're talking about 100 million patients in aggregate over many years. And something like, I mean, it's bizarre. It's like 250 billion lines of data. The real issue is that children and actually employed adults get their insurance primarily from commercial insurance through their employer. Commercial insurance plans data is not available if you want to name names, which is what we did. And so we're not able to include commercial, and that means pediatric, unfortunately. Now, if there were ever a regulatory or legislative thing that I would push for, it would really be that we create anonymized data of the commercial sector so we actually understand what's going on there. You can get, a peek at the data. You can get a slice of the data, but God forbid you ever actually name any names or talk at all about their pricing. Because the dirty secret that everybody knows is that commercial insurance and employed people who generally are healthy in their 30s and 40s, what hospitals get paid and what the healthcare system gets paid is some multiples of Medicare. And historically, it was framed as Medicare doesn't pay enough. But really nowadays, I think it's more that that's where a lot of the lucrative kind of remuneration is. And that is hard to pry loose into the public domain.
All right.
So regarding payer transparency, even it's hard to get Medicaid data on actual payment. You can get fee schedules, you can do a lot of research to figure out how broken the system is, but what would it take to be able to get payer transparency from Medicaid regarding claims paid, not fee schedules?
Yeah, well, it would take a lot of shoe leather, a lot of time, a lot of resources. I mean, it's likely doable, but the other part about Medicaid is it's all state by state. So you'd really have to kind of put on your hiking boots and, metaphorically, and go through 50 states to do it. Now, we've thought about that. We don't have the resources to do it, but, were we to ever get a, big fat grant to do that kind of work, then it would be well worth doing for sure for Medicaid. And, if anybody's been following the income inequality work in the country, there are a lot of people on Medicaid these days. I mean, a lot.
And we do have students and graduates probably from about all 50 states. If you ever do get one of those big grants and need some help, I'm sure you could find some here.
Well, that is a fantastic offer. I mean, I will not forget that.
Well, it looks like the questions have slowed down a little bit. But Rebecca says she'll buy some new shoes for that. I want to thank you so much, Dr. Saini, for coming and talking to us tonight, introducing the Right Care Alliance, telling us about the Lown Hospitals Index. I think it's really been invaluable, and so we really appreciate your coming tonight and taking the time to do this.
Well, thank you so much. I appreciate the invitation, and I'm delighted to have so many people interested. And I hope we'll see each other again in the near future.
Definitely. All right. Well, have a great evening, everyone. Thank you for coming. And I'm sure that, like I like to tell the presenters that come to these, that you are speaking to people, providers in across the country doing all different sorts of things. So even just what you presented tonight will have a pretty wide impact that you may not even realize. So
Great.
very much, and have a great evening.
Thank you. Thank you. Good night, everybody.